So this is again from McNamara, a very famous orthodontist from Michigan, done a lot of studies on monkeys, and really saying we can remodel the condyles by adding vertical or stimulating this by putting devices in these monkeys' mouths. So we know that this condyle can remodel. So initially it's adaptation and muscular function. So initially, first 2 or 3 days, whatever, it's like your muscles are holding the jaw forward. But after a very short period of time, it can be permanently forward and it doesn't go back. So you get a morphological changes in these patients fairly quickly if you don't really get them onto something like the AM liner. So this is just kind of a cartoon of how the jaw joint and the disc works. And we know we have a thin part of the disc, a little pocket, almost like what I call the pocket of a catcher's mitt. And as that condyle moves forward and the thin part moves forward and it's and then the disc follows it, and the blood in the disc behind the retrodiscal tissues move forward. And then as you move back, that thin part of the disc moves back. So that's a typical normal condylar disc function.
Now, one of the things to keep in mind is that every single joint in every patient is an adapted process because it's adapted to the function that the patient's put itself in, the orthodontics that the patient might have had, what they've chosen to chew, how they grew up, all kinds of things affect this system here. So there's an adapted jaw joint in the left and right of every single human that you see. So as you bring your patients in, it's a great idea to get a thorough history of what has gone on for their jaw joints and do a good assessment. You don't need MRIs and X-rays, and you don't need to be a TMJ expert, but you do need to be able to assess for what you're dealing with. That way you can set expectations appropriately for this.
So with condylar remodeling, in the first slide, the patient is not able to get back. So the retrodiscal tissue fills into that space, and then we have condylar remodeling, chondroblast, and what happens that our jaw and the condyle grows back and up, and actually the fossa remodels. So now all of a sudden we've got a longer condyle, the fossa is remodeled some, and I think we may get a lengthening of the mandible itself. So that's what I visualize as what's happening with the condyle.
If you study CBCTs, if you have one of those, and so you get a really good view of the condyle and ramus complex, you can watch, you can see some pathologies. You can see flattening of this and straightening of that. So under pressure, these bones are definitely remodelable, right? And so it's unreasonable to think that if we add some pressures going forward and therefore retrusive pressures from the attachments of those tissues to that bone, it's kind of unreasonable to think nothing's going to happen. Why would it not happen? So as we contemplate remodeling of this complex, it makes logical sense. So now, what are we going to do about that?
So our goal, obviously, is to reestablish their presenting occlusal and maxillomandibular relationship in the vast majority of patients. We don't necessarily want them to come forward unless we really plan on that. So what I found out is what we want this incredibly simple, very quick, and relatively inexpensive to have these people get back to what their normal occlusion is, and that it's easy to use. So this is why we came up with this device. initially, and we had a different one we'll show you, and now we've got this one. Several different things, very quick to use, easy to understand how to heat it, and then we put a handle on it so that the patient can grab hold of it and put it in correctly.
As you'll see it function a little bit, it captures slopes of the teeth. And those slopes are what guide the jaw back to where it came from, because those same slopes program the coordination of the closing muscles to put all the parts back in the right place. So we'll use those same slopes, that same proprioception, that same muscle memory to reestablish occlusion.